Welcome to Friday RLR, where Prof. Rez and colleagues were talking nuances about beards, and today, hopefully, we're talking nuances about medicine. And there's your in, Prof. Rez, to keep talking about said beard, said beard if you want to. But we're really excited to have you all. Before I pass the mic officially to Prof. Rez for him to say hi to you, would love for a case presenter from the crowd today. So if you have a case, anything from a UTI to poems is totally fair game. So please let us know if you have a case that you would like us to present. But in the meantime, Prof. Rez, hello.
Good morning, everyone. I'm very excited to discuss a case today. Hopefully it's one that challenges us. And although all cases, honestly, are challenging, like the other day, Robbie presented me a case of unilateral lower extremity edema. And then I found a review article where the authors reviewed 65 papers on approaching unilateral edema in some way, shape, or form. And I learned so much. For example, the tempo is really influential in the differential diagnosis of unilateral edema. And then Robbie, I learned even with venous insufficiency, you can get a duplex ultrasound, not a Doppler, a duplex, which combines two modalities of ultrasound to confirm that there is venous insufficiency. So in your patient who that was the working hypothesis, but had zero skin changes of venous insufficiency, where the diagnosis was questionable, then the clinicians could have got a venous duplex, if not getting a CT abdomen and pelvis, to ultimately diagnose the lesion of lower extremity edema. So the truth is, there are cases which will challenge us in any way, shape, or form. It seems like, does someone have a case, Robbie?
I wasn't going to interrupt you because the wisdom was so good. But yes, somebody directly messaged us. I didn't know that. I didn't know that there was I didn't know that there was a duplex ultrasound. And I have your article. It looked so rich. I was like, there's no way I'm gonna read it on a weekday. Like I can't wait to like sit and spend a few hours reading it. Rez, by the way, do you want to tell people where this case is? I don't think many people may not know where this case exists.
Oh, so this case is on rlrcpsolvers.com. It will be the case that we release on the main podcast. We do one a month, but we do it every week on RLR CP Solvers. The thing is, Robbie, whenever I encounter something like duplex versus Doppler, that's like so intricate. And I try to read a bunch about the two ultrasound modalities. So I read that the duplex will tell you if I didn't even know there was a test for venous. I thought we just diagnose it. Yeah. So I have to run that by like a vascular surgeon or someone in the audience who's really familiar with this stuff. Like whenever I never used the device, I'm very cautious, like rather than drawing a conclusion, because just reading it isn't the same as like practicing and applying.
I completely agree. That is awesome. Well, thank you I can't wait to learn more from you about that. But yes, we do have a friend from South Africa who messaged us directly and has a case. I'm not 100% sure how to pronounce your name, but I think it's Hans or Hannes.
Yeah, it's Hannes. That's correct.
Hannes, really nice to meet you. Do you want to tell us a little bit about yourself?
Sure. Thanks, guys. I'm really excited to present this case. I'm from South Africa. I'm in a coastal town called Knysna. Nice. It's more of a tourism destination, but we've got a lot of retired residents here. So I've got a big geriatric practice. But yeah, I've just been obsessed with clinical problem solvers for the last 2 weeks. It's been something amazing. I've got an internal medicine private practice. So one really loses touch with, the academic side of medicine. So it's great to, touch base with you guys and discuss cases and just get a little bit of academic medicine back. So that's wonderful. I must commend you also on this platform. I think more so than the content, how supportive you are of everyone. The encouragement that is given, that's really great. I'm from I think a different culture of medicine where there's still a hierarchy of power, and students are taught by humiliation, and there's a big power difference or differential. So it's really great to be part of this team and this community.
Well, there's such kind words, I think they stand on their own, but I will say that the only reason this community exists is because it draws and attracts people like yourself. And so I think it just propagates that culture that you're referring to, only because people who identify with that stick on to this, and people who don't run very, very far away. And sometimes we hear from them, actually, believe it or not. Prof. Rez will
Sure.
attest to those moments. But we're very, very glad that you're here. And clearly, Prof. Rez is a huge fan. I've seen nothing but his teeth so far.
Great.
Thrilled to have you. Thank you so much for joining us. We're really excited to get to know you better, and hope that your obsession turns into many, many years of us hanging out together. But yeah, we're ready whenever you are, please. I'll have Prof. Rez
Great.
take the
Thank
first
you.
output.
Thank you. So the case that I've got is it's a 69-year-old female. She was brought in to the emergency department by her daughter. And the main complaint really was an episode of fainting. And the episode was described as a sudden onset of weakness. There was some sweating involved. The patient described a sensation of a veil being drawn over both eyes. And then there was a loss of consciousness. But she awoke soon thereafter, and there was a bit of lethargy for about an hour after this episode. She didn't report any headache after the episode, and there wasn't any incontinence of urine or stools. Just on some further questioning, she describes these episodes of being recurrent. They occurred a couple of times over the last 6 months. And she has been to the emergency department before, also complaining of pain in her left shoulder and arm, but investigations, ECGs, x-rays of the shoulder was normal at that time. So that was the history, and I think the first aliquot.
Hannah, it's so nice to meet you on this platform. And I was typing in the chat that I can listen to you speak forever. And quite frankly, I'm a bit distracted right now. Focus more on the accent and how pleasant it sounds to my ear than the medical information. But I'll tackle this first aliquot and then ask Robbie to add anything that he wants. I think there's something really important here. A couple things. One is the clinical syndrome of fainting. And I said fainting and not necessarily syncope for a specific reason, because I don't want to narrow my differential diagnosis. So loss of consciousness. And then the second element of this aliquot that's most important is the sudden onset. So this isn't something that is gradual, but suddenly this 69-year-old woman experiences this symptoms. So if you ask the question, what can lead to transient loss of consciousness? And that's really the frame you want to use instead of syncope, because you don't want to anchor. No one ever comes in with the complaint of syncope. They come in with the complaint of loss of consciousness. So immediately when I saw this, reflexively, if you're in the emergency department, you're obtaining a point of care glucose, because hypoglycemia and any almost metabolic disturbance can cause sudden onset transient loss of consciousness. Another diagnostic consideration here is seizure. Seizure, I think we don't diagnose enough, especially non-convulsive status, where the patient is just not showing any rhythmic movements, but really is having electrical abnormality within the brain that's leading to transient loss of consciousness. The thing that makes seizure potentially less likely is the lack of rhythmic contractions, the lack of urinary incontinence. But on physical exam, you're going to want to look at the tongue, because that ends up being a very helpful clue if there's any lacerations on the tongue. Stroke is very unusual to cause transient loss of consciousness. And the fact that this patient has had 6 similar episodes or 5 to 6 similar episodes makes that unlikely. So I think if I were to prioritize my list, it would be syncope versus hypoglycemia, and less likely seizure, stroke, and something psychiatric. So then the question is, can we make any more progress on these hypotheses? And the truth is, I think we'll need more information, but immediately syncope is much more common than hypoglycemia. So you have to think about cardiogenic, orthostatic, and reflex mediated causes of syncope. I don't know how to yet integrate the pain in the left shoulder and arm. Honestly, like I have pain in my left shoulder, so it can be totally separate than what is happening here. But I think that is really the frame is transient loss of consciousness, recurrent episodes. The past medical history, the physical exam, and a point of care glucose will allow us to make much more progress. Robbie, anything to add?
Not at all. I think that landscape is absolutely superb. You know, I'm always intrigued when somebody says that they're sweating, because I think that it's such a unique marker of what is going on in the body, anchored in the complex pathophysiology of sweating, which is that it is actually the only place where the parasympathetic system and the sympathetic system interact. How does that happen? It happens because the sweating neurons are sympathetic neurons, as you would expect when sympathetic and you want to sweat, but the receptors are parasympathetic. They're actually muscarinic receptors. And so both an increase in sympathetic tone or parasympathetic tone can result in sweating. And what are the examples to layer onto Prof. Ress's approach is when you have vasovagal discharge, one of the things that your patients will experience is a profound vasodilation and diaphoresis. Clearly, all right, not a little bit marky today. Hold on. Hey, stop. That's not going to work. So I want to go do this, but I will say that amongst the causes of syncope, I'm really intrigued about the possibility of vasovagal based on the diaphoresis, but I think the sympathetic arm also highlights the possibility of hypoglycemia that Prof. has outlined. So when people sweat, pay attention to it, especially when they're non-exertional sweats, they're not running and sweating. That is a marker of either excess sympathetic tone, hypoglycemia, pheo, so on and so forth, or the abrupt rise in vagal tone from vasovagal syncope. All right, Hannes, we'll lean on you to tell us more.
Sure. So in terms of a previous medical history, she is known with adenocarcinoma of the lung. And that was diagnosed in 2021, but opted for no treatment. Further, also known with a history of pulmonary TB, that also had TB pericarditis as a complication, also 2021. And she completed treatment in May of 2022. She's also known with paroxysmal atrial fibrillation that was diagnosed in 2021, and also a diagnosis of chronic obstructive pulmonary disease. In terms of the social history, she smokes cigarettes, smokes about 30 cigarettes per day. Previous excessive alcohol use, currently about 2 to 3 beers per day. Family history. Of note, there are some malignancies on her father's side of the family. Then in terms of surgical history, she had a hysterectomy. In terms of allergies, she's had previous reactions to streptomycin when she was treated for TB in the past. And then just her current medications, she is on bisoprolol, amiodarone, rivaroxaban, but she only takes that intermittently, haphazardly, and then she uses an inhaler, a fluticasone vilanterol inhaler. And I think that's where that aliquot would end.
Hannes, this is so surprisingly complex, and I think I'll tell you why I'm surprised, and just reflect briefly, and then pass the mic. I'm surprised because I think my mind has been encoding this as a recurrent episodic disorder, meaning that the patient is between these episodes fine, and I think the probability of that happening in such a complex host is unusual. because most people who have recurrent episodes of things, usually we assume that they're okay in the middle. And it's hard to believe that somebody with this complex medical history actually has a normal resting baseline. So now I'm actually resetting and saying, I'm not so confident that my grasp of the history is actually as accurate as I thought it was. And so that is going to be a key hole in making sure we end up solving the right problem and not assume this is recurrent episodic. And just the inferences you can draw from medical history are infinite when you have a cancer that couldn't progress, especially if it's untreated. The amount of connections you can make with cancer her presentation are too large for you to just list them now. The good news is when TB is treated properly, it doesn't usually come back. The successful therapy of TB is very high. However, chronic fibrotic complications of pericarditis, like constrictive pericarditis, are the exception to that. You may not heal that at all. AFib and syncope are extensive overlaps, usually not through AFib with RVR, which is first felt as palpitations before the patient syncopizes, but rather through the progression to sick sinus syndrome. So that's something we'll have to think about too. And that hypothesis is further reinforced by the presence of an AV nodal medication like amiodarone. And then her social history is rich for further complications from alcohol use and the hard alcohol use and hypoglycemia. So I think what this does for me, honestly, is I would not in real life be making any concrete hypotheses, but to humbly acknowledge that the spotlight is now massive. But the key thing that I would go back and do is really talk to the patient and now establish, how are you between these episodes? And what is your baseline then? Prof. Fred, thoughts?
Yeah, I totally agree. Very complex background. I think it just lowers my diagnostic threshold for a CT scan when the time comes. We'll see what the physical exam is, because I want to know this untreated adenocarcinoma, if it's metastasized anywhere, if it's causing any type of compression, what's the disease burden that may link to the patient's transient loss of consciousness. So what this background does, it just really lowers my diagnostic threshold for invasive imaging. Back to you, Hannes.
All right, so on examination, this lady, she had a slight build, chronically ill appearing. Blood pressure was 111/66, pulse 76, and temperature was 36.2 degrees Celsius. She had saturations of 91% on room air. Then in terms of the cardiovascular examination, she was in sinus rhythm, pulse regular, her JVP was normal, heart sounds were audible, there wasn't any extra sounds, no pericardial rub audible. On the respiratory examination, hyperinflation was evident, some diminished breath sounds, but symmetrical. In terms of her abdominal examination, soft abdomen, not tender, no distension, no organomegaly, specifically no hepatomegaly or splenomegaly. Then in terms of her neurological examination, she was orientated, didn't have any neck stiffness. Her cranial nerve examination was normal, and power was normal bilaterally, all limbs. Sensation was also normal in all of the limbs. So that was the physical exam.
And I think, Hannes, here, what's interesting is that there isn't really anything that's jumping out as to the cause of transient loss of consciousness, but that's not necessarily reassuring, because we know that the insult is transient in nature. And so ideally, in a patient who has transient loss of consciousness, you capture their environment the moment they're experiencing the transient loss of consciousness, meaning you give the patient a blood pressure cuff at home. You give them a point of care glucose monitor at home. You want to know what is their heart rate when they're experiencing this, when they're awake. So this is not necessarily reassuring. I noted the oxygen sat is on the lower end, but this is a patient with COPD, continues to smoke. So I wouldn't be surprised if that's where the patient lives. And I think at this juncture, really, the labs and imaging are going to be potentially helpful. I think what this does is that if you think of syncope and you think about the core causes being cardiogenic orthostatic reflex mediated, this makes a structural cardiac process less likely. It makes orthostatic process less likely because we're not getting much of a story for that. But the rhythm disturbance, the reflex mediated, if there's like a mass compressing one of the nerves, and metabolic stuff like hypoglycemia are all fair game at this juncture. So what would I do? I would wait for the labs, maybe check. Yeah, I would wait for the labs, to be quite frank. That would be my next step in this workup. Robbie, anything to add?
Oh, 0, 0, 0. That was awesome. I know. I love how you taught us to interpret the oxygen saturation in the right context. It's almost like the sensitivity of this exam is reduced because the patient's not ill as she's reporting, and the findings have to be interpreted in the context of her known diseases. Those are subtleties, but they're really, really important. Love it. All right, Hannes, tell us more, please.
Sure. So I'm going to present the special investigations, the labs, imaging, but I'm going to also present it as in real life. How one went through the labs first, and then back to the patient, and then the labs, and back to the patient. And at some stage, there was a pivot point.
The reason we love that, Hannes, is because you're really mimicking what we experience, and as opposed to this fabricated, let me give you all the information. So thank you for that.
Sure. All right. So in terms of labs, the CBC HB 13.4, white cell count was 13.6, and platelets 273. Then in terms of the BUN, sodium 135, potassium 4.9, CRP, urea and creatinine was normal. CRP 6.9 and ESR 36. And glucose was 44. TSH was normal. I'm not sure which units you use. Ours was 0.69, but that was normal range. And then we also did a random cortisol level, which was 486, which was normal. Then moving to the ECG, she had a sinus rhythm, 75 beats per minute. No real changes there. The PR interval was mildly prolonged. QRS complexes were normal. QT corrected time was 472. No signs of ischemia. All right, so the chest X-ray really just showed what we knew, that showed hyperinflation. And it also showed the pulmonary mass, which was previously identified, which was the adenocarcinoma. No signs of pleural effusion. And an echocardiogram was also done. so the echocardiogram was basically normal. It showed a normal left ventricular function, no signs of right ventricular strain. There wasn't any pericardial effusion, and also no evidence of a constrictive pericarditis. All right, and then we also requested an MRI brain, but that was quite unremarkable and didn't show any conclusive evidence of metastatic brain disease or any other discernible changes. All right, and then we also requested a 24-hour Holter ECG, which did show episodes of paroxysmal atrial fibrillation with a maximum ventricular response rate of 160 beats per minute. But these were short-lived, lasting about 2 minutes at maximum. So those were the initial investigations.
As such a thorough workup for this patient, I think it's so telling of how it maps onto the schema that Prof. Rez outlined earlier: syncope with the EKG, the echo, seizure with the MRI, and then sugar with the hypoglycemia. And if you look at all of them, the one productive one has been the hypoglycemia. And I think before you commit to that being the cause, you just have to humbly recognize that measuring the serum glucose can be a little bit complicated, and depending on how it's measured, it may be inaccurate. So if you get a venous sample from a peripheral IV or a poke, that can be artificially low in the face of a very high cell count, be it white blood cell count, hemoglobin, or platelets. And the lack of those marked elevations makes that hypothesis less likely. If you get it from the finger stick, that can be a little because of low flow or low perfusion, but that doesn't appear to be the case here. So I think it's easy, especially mapped onto the pretest probability that Prof. Rez, it's easy to skip by that and assume that this glucose is true. A neat trick to be more confident is to get two simultaneous glucoses from the vein and from the capillary stick, because they're wrong for different reasons. And so if they are both aligned, you're very, very confident that the patient is in fact hypoglycemic. And at this time, presumably she wasn't overtly symptomatic, so you can only conjecture that she was even more hypoglycemic beforehand. And so I'll just take a moment to sort of paint the big picture schema and the branch point of hypoglycemia, namely trying to figure out if it's insulin mediated or non-insulin mediated, and then pass the mic to Prof. Rez to add to that and then analyze it. And so I think the exercise of trying to distinguish insulin versus non-insulin mediated is imperfect. It's a best guess, and one that awaits the insulin level or the proinsulin level for confirmation. But since those tests take some time to return, it's a productive exercise to try to be a step ahead. So that's why we do it. And how we do it is we use 3 factors, and if we really need to, a 4th additional one. And those 3 factors all hinge on understanding the mechanism of action of insulin. Insulin is an anabolic hormone. It usually is released in states of overall well-being. So the patient usually actually is doing well and gains weight. What it also does is it rapidly pushes glucose into the cells, causing prominent severe hypoglycemic symptoms. The final thing it does is it completely suppresses ketone production. And those 3 things release in overall anabolic, happy, well-being, fed states. Rapid pushing of glucose into cells and suppression of ketosis are the tenets of trying to figure out if a patient has insulin-mediated hypoglycemia or not. So if hypoglycemia is your problem number 1 and your patient is otherwise well acutely, it's probably insulin. If your patient has prominent neuroglycopenic symptoms to the point where they pass out and are confused, it's probably insulin. And to add further argument to that hypothesis, suppressed ketosis, so no ketones, a normal beta hydroxybutyrate, and or normal urine acetone measured on the UA would be very, very supportive. So we have 2 out of those 3 here. We don't have the ketones, but those 2 would both align an insulin-mediated mechanism. So the final thing I'll just say for teaching purposes, if you're not sure and you really, really want to know, you can do what's called a glucagon stimulation test. That's very rarely done, but it's done for academic purposes. But it's good to know it purely for the teaching, which is that in insulin-mediated hypoglycemia, there's actually no net hypoglycemia. The patient's net overall euglycemic. It's just that their glucose is all stuck inside their cells, not in the serum. And so what glucagon does is it brings back the sugar that was stuck inside the cells, resulting in hyperglycemia. In stark contrast, non-insulin mediated hypoglycemia is a total net body deficiency of glucose. There is none anywhere. And so glucagon does nothing for those patients, which is why if your patient overdoses on insulin, guess what you treat them with? Glucagon. But if your patient has a non-insulin mediated hypoglycemia, glucagon won't do anything for them. So I think we have a decent case for insulin mediated hypoglycemia. One more data point would be very helpful. But remember, this exercise is a best guess pending confirmation of insulin levels. Profres, thoughts on that and what might be going on?
Dude, as you're teaching us in such epic fashion, I have this like muscle strain in my back. It was like killing. I almost like fell to the ground, but I'm okay. Thanks for asking, Robbie.
How are you, Profres?
I'm all right. You know, I'll be honest with you. So this is very tricky scenario for one major reason. Oftentimes when you do have an insulin mediated process, as you mentioned, Robbie, and taught us, the patient is healthy. Like the patient appears well. How do we reconcile that with the patient before us? Like if you look at that past medical history and you say there's progressive cancer that hasn't been treated, recent history of TB, advanced COPD based on that oxygen saturation, probably. Meaning that this patient is, at least based on the background data, is giving us the phenotype of someone that would be hypoglycemic because just the nutritional demand of the body has diminished, for example. So I think, Hannes, can I ask you a question? I know you told us this patient was ill appearing. What was her weight or body mass index?
Yeah, so her body mass index was around 16.
16.
16,
Okay.
yes.
Thank you. So that's quite low. And the reason I'm bringing this up is because I remember I had a patient on service who drank a lot of alcohol and was malnourished. And every time we checked their point of care glucose, it was like 44, 45. And every time they wanted to transfer this patient to the ICU. But the patient was totally asymptomatic. We checked the hemoglobin A1C and it was like 4.4, something really low, meaning that patient was living at those low glucose levels over time, over a period, like very slowly. So I think, Robbie, what's really challenging here is we still haven't identified a cause of transient loss of consciousness. And because we haven't, of course, we got to pay attention to the glucose. But if you tell me someone with a BMI of 16 has a glucose of like 50, I wouldn't be too surprised, to be honest. Now, a very important teaching point is in someone who's healthy, if their glucose is above 60, that's not the cause of the symptoms, whether it's transient loss of consciousness, whether it's the autonomic surge that you get. And why do we get that? Because you're seeking sugar. Your brain is saying, go get sugar before I lose consciousness. But in this patient, you got to be cautious, I think, before blaming the glucose. It may be the glucose, and that's just because of who this patient is, what her body mass is. So I don't know yet. I think we have conflicting data here where we don't have an alternative etiology. But what I do know is the following, that this patient should be on, the patient already was on tele for 24 hours. And the next time this patient has sweating or any kind of symptom, we need a glucose in that moment. Because in that moment, the glucose, if it's 20, then you're done. It's hypoglycemia induced transient. But how odd is it that someone has adenocarcinoma of the lung, has TB pericarditis, and then also has like an insulinoma, or maybe has an antibody to insulin? But I would love to dance with you a little bit, Robbie, here. What are your thoughts on that sort of take?
I completely agree with you. When you study the overlap of cancer and hypoglycemia, you will 99 out of 100 times, even 99.99999, as you like to say, you will land in the world of non-insulin mediated hypoglycemia. And I think I'm trying to pull it up visually just to share with people that this is the schema that I use to answer that question. And look, insulin, super rare. All these things, the prophylaxis outlining malnutrition, liver and kidney disease, the Warburg effect, which is usually seen in aggressive lymphomas and adrenal mets. And we've ruled this out to some extent with the cortisol. This is usually somebody who's critically ill, who has a high LDH, high lactate. There's no kidney or liver disease, but this is a very prominent role. So I think, practically speaking, Prof. Rez, I think the base rate would have us favor this quite significantly. The tension for me, and the reason that there are two reasons that I think that I would go beyond that, even though that I would go beyond stopping, because I think you're right. And most people, you would actually just stop. You'd say, this is the cause, and let's get a nutrition consult and let's discuss whatnot. The reason I think I'm inclined to go beyond that is twofold. One, we're in VMR. Let's be honest, this is a total VMR bias. The other one is a law of proportionality. You know, the electrolytes are not abnormal. The creatinine's not abnormal. Actually, no, I made that assumption. I don't know, Hannes, if the FOS and the MAG and the, like it's just a general gestalt that the only number in red is glucose. And that's a little weird for malnutrition. It's a little weird, but is it weird enough? No, malnutrition is so common. But is it weird to push us forward? Yeah, I think the patient has an undescribed, unsolved clinical syndrome, and the glucose is a little bit out of proportional. So we might have to open up that separate schema of insulin mediated, or we might not.
I am 100% with you. And I think what I think one of my major goals is you really want to be as sincere to the exercise, as we often are, as possible. There is that VMR bias, but you want to avoid that. In reality, if this was my patient in the hospital, I would say, okay, I note the glucose, but her BMI is 16. What I need to see is what happened. Like, I would monitor in the hospital without a doubt. I want to know what the glucose is when she's having the major symptoms. Because right now, if I do send an insulin and her glucose, let's say she lives in the 40s, I wouldn't, expect to see a high insulin, a high C-peptide, et cetera. So I think I would send an A1C to get a sense of what her normal glucose is. I would look at prior blood glucose. I would monitor, and the moment so I think there's enough for me to question the possibility of hypoglycemia, like you said, but not exclude it, but then track the patient and see how I would respond.
I'll just throw in one thought. I think the ketones here might be really helpful, because in malnutrition, you'd really expect them to not be suppressed. And so I think that data you'll have for free. And so you might consider getting that earlier on to help you in that calculus.
I love that. So a beta hydroxide, that would be a very helpful point.
All right. So we can talk forever. So take us forward, please.
Sure. So that's exactly what we did. We put the patient on telemetry, tried to correct what we could correct. She had an IV up, just containing some dextrose. I was called soon thereafter that she was having another episode. The first question was, what is the glucose? So the glucose at the time of this episode was 108 on the dextrose IV. And I arrived at the high care unit, saw the patient, and the blood pressure was also low. It was 81/47. But what was interesting for me is that the BP cuff was on the left arm, because the IV was on the right arm. And I thought, but that wasn't her emergency department blood pressure. And immediately did a quick reevaluation. We found that her pulses were discrepant in the upper limbs. So quite a well palpable right radial pulse, but couldn't really palpate the left radial pulse. that led me to request the next day, because this was also a short-lived episode. The patient quickly recovered consciousness again. She didn't have any signs of arrhythmia at that time, also when she had the episode. So that just led us the next day to request an arterial duplex Doppler of the upper limbs. And that result said that there was dampened monophasic flow within the left axillary, brachial, radial, and ulnar arteries, indicating a more proximal stenosis, which then led to a CT angiogram being requested of the neck and aortic arch. And this showed signs of diffuse atherosclerosis of the aortic arch, with a high-grade stenosis of the left subclavian artery, immediately proximal to the left vertebral artery origin. And there was also some signs of bilateral carotid bifurcation disease, and a stenosis approaching 50% of the right proximal. That was the internal carotid artery. Yeah, so maybe I should just leave it there for the discussion.
What a case, Hannes. I do want to say that I think we had this hypothesis of hypoglycemia, and here we have a patient who has symptoms, but the glucose is high. So that eliminates that possibility of assuming that the sample was correct. And I think we have every reason to believe it was correct based on an alternative explanation for this patient's transient loss of consciousness. And I think prior to you, I mean, that's insane. Like, I wouldn't have even thought to measure blood pressure in both cuffs. And I know it just happened serendipitously because the IV was in one arm. But that's fascinating. And I would love to hear from Robbie how we may have arrived at the diagnosis sooner, if there's any clue with the back. I have no idea, but let me share with you what I think is going on here. So I think the problem we have here is subclavian steal syndrome. And just to do a quick 30-second teaching on it, but basically you have some kind of stenosis in the vessel, and this results in a decreased pressure in the arm distal to the stenosis. And that's what Hannes told us. The arm, the Doppler, the blood pressure, it was lower. And ultimately, the pressure being lower, the arm's like, wait a minute, I don't want the brain to get the pressure. I want the blood. Why should the brain get it? So it steals it from the brain. And when it steals it from the brain, here are the symptoms you get. Dizziness, syncope, you can have diplopia. And this is the exam. There's greater than 15 millimeters of mercury, but you have to be so cautious because some people can just have stenosis without steal. And the majority actually that do have stenosis do not have steal. Look at the right where it says educate right here, the EDU. And then finally, here's who gets it. Most often peripheral arterial disease, but there's thoracic outlet syndrome, which I think we have to worry about in this patient with the lung cancer. And yeah, and vasculitis, but I'll pass it to Robbie to see what his thoughts are here.
Prof. Rez, I love that visual. I still remember the case that prompted it. Yeah, I think it's just goes to show you it's a very, very hard diagnosis. And I think it requires a lot of careful observation that Han has made. It's that leap of that observation that I think allows you to like make that inference. And for me, I think, gosh, it's such a hard diagnosis to make, in large part because the proximal diagnosis of syncope is hard to make. And I actually don't even, I think it's so hard to know where this lives, because the whole notion of syncope is a transient drop in cardiac output. But yet in this instance, there is no drop in cardiac output. It's merely just a shunting of blood away from the brain. And in fact, when you look at the history, there might be a little bit of a hidden clue in the history in that she had prolonged confusion, or just was a little off for a while afterwards. That may have been a clue. That's the only clue that I can think of in retrospect that suggested that there is a kind of like a focal brain issue. But it's a really, really hard diagnosis to make. you are inclined to kick yourself a little bit, because in real life, if you study if you do a good pulse exam and you're good at pulse exams, you might notice a discrepancy between the right radial and left radial pulse, but I'm not even close to being that good at my pulse exam. So for me, Prof. Rez, I think every time I've heard of subclavian steel be the answer, I think there is usually a very powerful piece of sort of almost heroic data discovery. And I think we were talking about this with another case that folks don't know about yet, where getting the data is so much more important than reasoning. Like if we hadn't heard from Hannes how he got this data, I don't know if I ever would have thought of subclavian steel. So I think, Hannes, you're demonstrating that importance of shrewd data procurement. I don't know how data analysis alone could have gotten us there.
I love that, Robbie. And I would love to hear from Hannes in addition to the case conclusion, because I'm sure you've thought a lot about this case, Hannes. Like, if there was any way you or any of us could have suspected this before we arrived, like, I have no idea, and like Robbie, but I'm really curious to see what your style is.
No, I don't think, there was any way to get to the diagnosis. I mean, there was such a complex history and so many conditions that could have caused the syncope, that it was really, like you say, Robbie, by chance that one saw that there was a discrepancy in blood pressure, and then the penny dropped. So yeah, I don't think, and for me, you would always, even after you saw the imaging, you would still think, is this the correct diagnosis? And I think for me, the proof was we did refer her to a vascular surgeon. She did have a balloon angioplasty of the left subclavian artery, and I've seen her for a couple of follow-ups, and she's never had a return, of the syncope. So for me, that is proof that I was on the right track.
Yeah, I think Prof. Rez just made that point in the EDU section, like how many people have asymptomatic disease and you have to prove that they have it. And I think response to therapy is the best proof out there. Hannes, I think, as Prof. Rez alluded to, would love for your reflection on going through this journey. I mean, you lived this. We merely discussed it. What was it like to take care of this patient and to come to this conclusion?
And by the way, Hannes, as you said that that you're far from academic medicine, I don't think it's more academic than this in solving a problem with all these tests. This is A+ medicine.
Sure, but it's so great to bounce the ideas off each other, than opposed to having a conversation with yourself in your head. But no, it was a very challenging case, because you've simultaneously got the pressure from the family, the concerned daughter to get an answer, why is this happening recurrently? So I think it was really, really challenging in that respect. A patient who's also known with what is quite a terminal diagnosis, not opting to have any treatment, the balance of, how far should I investigate? How far should I intervene? I think that also clouded the picture a little bit, but we decided to persist, and got the answer in the end. And I think at least then provided some quality of life moving forward, in terms of the reducing the number of syncope episodes.
Yeah, I think that at the end of the day, we can all make, I just love that final point you made. We can all make some judgments about, when somebody has a progressive malignancy, about what they may or may not want to intervene on. And you're going to hear showing us and showcasing us that these episodes were so distressing to her that they were worth intervening, even though the cancer itself wasn't. And I think, being alive and being a human being is so complicated that you can never expect what people want and don't want to intervene on. And so Not only is this a great demonstration of a very complicated case, and also just like shrewd pickup of a very subtle clue that you could easily have overlooked, I can see that, but also just integrating the complexity of taking care of a human being who has wishes that are way more complex than I think anything or anyone can predict. That was really, really cool. Thank you. Well, we learned a lot from you, Hannes, today. We really, really hope that we get to see you much more often. And we'll pass the mic to Maddie to take us home with the teaching points.
Thank you.
All right, I just want to echo Hannes, thank you so much for stepping in and presenting the case. Just truly, there was so much to learn from it. So jumping into the teaching points, so we started with the frame of transient loss of consciousness, and we broke down the differential into syncope, which can be cardiogenic, orthostatic, reflex mediated, metabolic disturbances like hypoglycemia, seizure, and stroke. We really kind of honed in on syncope because seizure was less likely given the rhythmic contractions, lack of tunnel lacerations, or urinary incontinence. And stroke was less likely given that this was 5 or 6 episodes. We also got from the HPI that the patient reported sweating, and we learned that sweating is an interesting concern because it's actually an intersection between the parasympathetic and the sympathetic nervous system, being that the sympathetic neurons are really responsible for sweating, but there's a parasympathetic or a muscarinic receptor. So if you think of things that can cause sweating, it's both excess sympathetic tone like hypoglycemia or a theo, or an abrupt rise in vagal tone, like vasovagal discharge. It's not on the board here, but I think it was really interesting just to pause to think about the discussion when we got the physical exam and how important it was to analyze that in the specific context of this patient. So for example, the SpO2 was in the 90s, but we didn't kind of jump to that given the history of COPD, and also the fact that it was a normal exam was not so reassuring because of the kind of transient and periodic nature of the symptoms. And then for labs, we saw that the patient had hypoglycemia, and we learned that the measurement of serum glucose can be complicated because the venous sample can be artificially low in the setting of a high cell count, and the finger stick can be low in the setting of low flow or perfusion. So one trick is to get 2 simultaneous samples from the vein and from the capillary stick. And the schema you can use for hypoglycemia is it insulin or non-insulin mediated? And really to determine that, you want to use 3 factors that are based on the mechanism of action of insulin. So that is 1, that insulin is an anabolic hormone released in overall states of well-being. 2nd is that it rapidly pushes glucose into the cell, so it can cause symptoms of hypoglycemia. And then 3, that insulin suppresses ketone production. Besides those 3 factors, you can use sometimes a glucagon stimulation test. And really, if it's insulin mediated, that's a state of no net hypoglycemia. So if you give glucagon, that brings back the sugar that's stuck in the cells, leading to hyperglycemia. Usually those patients are generally healthy or well appearing if it's insulin mediated. And then non-insulin mediated is a state of net glucose deficiency. So glucose actually does nothing in that case. Ultimately, when we learned that the patient had symptoms, but the glucose was still high, that kind of eliminated the possibility of hypoglycemia being the cause of this patient's symptoms. And then, we got some more data and really that kind of nailed the diagnosis here of subclavian steal syndrome and a little bit of the pathophysiology. So really, there's a stenosis of a vessel that causes decreased blood pressure in the arm distal to that stenosis. And the subclavian vessel, of the arm steals the blood flow from the vertebrobasilar system, which kind of leads to the symptoms of dizziness, syncope, and diplopia. But ultimately, it's really hard to suspect that diagnosis from the very beginning. So really getting the data of the discrepancy in blood pressure was key here. So thank you, Hannes, again for presenting, and this was a great case to learn from.
Absolutely amazing, Maddie. I can't believe you captured all that. That was so cool, from the nuances to the big picture all in one go. Thank you. All right, y'all. Hope to see you next time. Thanks again to Hannes. I think he just messaged that he might lose power, so might have dropped off. Thank you, Maddie. Thank you, David, for scribing, and the one and only Prof. Rez, and of course his beard, we will now consider a separate entity from Prof. Rez. Bye, y'all.